And really the springboard of what I'm going to be talking about today is the Canadian Guideline for the Clinical Management of High-Risk Drinking and Alcohol Use Disorder, which for those that are interested to read the whole document is available online in the CMAJ or on the CRISM website. But I'll share that the guideline used the Guideline International Framework for management of conflicts of interest. But I'll share, I thought for my talk today that I was the co-chair of the guideline, and I think that makes me sort of well positioned to address some of the comments and questions about the guideline insofar as it does represent some practice changing recommendations. But also, I'm a co-chair of the guideline, so you can recognize that in terms of that being a professional conflict as well. So instead of getting into sort of the, academic debate and that kind of thing, I thought I would try to bring things really down to sort of the patient level. Like, what would I want to know if I was a patient struggling with my drinking, and what I'd want to know? And among my professional areas, as my disclosure shared, I work at Vancouver Detox, a withdrawal management facility, and this is a very, very common clinical scenario. So a 48-year-old married employed father presents to his family doctor. He's complaining that he's drinking too much and he's been feeling down for a long, long time. So the family doctor tells him, listen, you have to address your drinking, and an SSRI antidepressant is started for the low mood. Let's say a couple of weeks go by and he returns without improvement. Maybe things, if anything, are kind of getting worse. And now he's complaining of poor sleep. He's really down on himself because he hasn't been able to address his drinking. So the SSRI dose is increased, and then trazodone, a sedating antidepressant, is added to support sleep. Patient ultimately presents for inpatient withdrawal management for ongoing severe alcohol use disorder, where he meets me. So a little bit about background about this guideline, and I'll come back to our case. This guideline, the co-chair, a sort of famous alcohol scientist named Dr. Jürgen Rem from the University of Toronto and the Center for Addiction and Mental Health. Jürgen and myself were all really excited because there's a couple of medications that don't get used as much as they should. Naltrexone and acamprosate. Studies show that they almost, historically almost never got used in alcohol use disorder. And we came in all excited to sort of, okay, these are the things we should do more of. And we had assembled a committee of specialists and primary care providers, people with lived and living experience, people that work in treatment centers. And they said, well, what about all the other medications? What about the trazodone? What about the Seroquel? What about the SSRIs? I remember someone saying, I get people on 2 SSRIs. What's the evidence? All this polypharmacy. What about those things? And so that sent this committee on a trek to go to the literature and just open our eyes and try and see, well, what about all these other medications that are commonly prescribed? And that ultimately led to these recommendations that SSRIs and antipsychotics not be prescribed for the treatment of alcohol use disorder, and really a practice change that even when there's an on-label indication, if somebody has anxiety or depression in the context of alcohol use disorder, do not use SSRI antidepressants. Now, there's a couple of truisms, and I'm coming with a lot of academic humility here, because this is kind of what I used to what I used to teach addiction medicine fellows when I was in clinic. They'd say, well, what's going on here? What's on the pre-printed order set? It looks like you're prescribing trazodone to every single patient who comes in by checking trazodone on the pre-printed order set. So there's a couple of truisms that maybe aren't really true that are out there for why this sort of polypharmacy approach is beneficial. The first is that antidepressants are critical for concurrent disorders to improve alcohol use disorder treatment outcomes. So if somebody's depressed and has alcohol use disorder, you have to give them an antidepressant if you want to have a good outcome from their alcohol use disorder. It's also argued that this is particularly true on those with polysubstance use problems. So when I say the majority of people with alcohol use disorder have polysubstance use challenges, I don't mean 90%, but probably more than 50% use tobacco, or they vape, or they use cannabis, or they might use cocaine or methamphetamine. Many use opioids as well. And they tend to have a lot of mental health problems. And there's been a big emphasis on that population to really bring them to specialists to get them on the medications to treat these mental disorders. It's often argued that medication should be routinely prescribed for a minimum of several months. Now, I'm a specialist physician. I know what specialists like to do. They like to see someone, refer them back to the family doctor, and say, if that doesn't work, send them back in 6 months. These are, harmless interventions. Let's try this. And this notion that let's just try these medications and see what happens is another truism. It's also argued that combining antidepressants with psychosocial treatment is really important. So oftentimes that's mutual self-help meetings, but if you can access cognitive behavioral therapy or psychotherapy, that and an antidepressant together is kind of the sweet spot. Add your alcohol use disorder medication, and that's the kind of milieu of intervention that results in the best outcome. And you'd think that in 2012, this is Therapeutics Initiative data from the letter that was published this week. You'd think in 2012 there was a big international phase 3 trial that proved that this is the approach, because of course we've seen in British Columbia, and that's where this data is from, a real dramatic increase in the use of these medications. So there's a couple of problems with these truisms that this alcohol use disorder guideline committee soon became confronted with. And the first is that serotonergic antidepressants are not particularly effective for treating mental health symptoms such as depression and anxiety and those with alcohol use disorder. Why do I know that? Well, because there's meta-analysis, and this is the sort of big, really high quality meta-analysis. It's not that old. It's from 2020. I don't think there's any new clinical trials since that time. It's a really esteemed authorship group. They did a really nice review, and they concluded that selective serotonin reuptake inhibitor-based treatments had no effect on major depression. So in some ways, particularly, I think, other areas of medicine operate a little bit differently, although maybe my therapeutics initiative friends would disagree. But I feel like in cardiology, if the big meta-analysis showed a medication was not effective, there would be deprescribing initiatives. There would be efforts to, avoid a medication that has costs and side effects, not to use it. And that hasn't really happened in our world of mental health and substance use. Now, one of those truisms that I shared with you is that combining an antidepressant like an SSRI with an alcohol use disorder medication like naltrexone, that's effective. And to be honest, there's been criticism of the Canadian alcohol use disorder guideline where that point has been made. But these investigators asked and answered that question, where they showed selective serotonin reuptake inhibitor-based treatments either alone or in combination with relapse prevention medication such as naltrexone had no significant effect. So that truism that you're going to get an antidepressant benefit of combining an SSRI antidepressant with your alcohol use disorder medication, and that's where they're really effective, that's just not true. Another sort of look at the Canadian alcohol use disorder guideline, people have put up their hand and sort of said, well, hang on a sec, what about the Cochrane reviews? The Cochrane collaboration, I think most of the people on this talk will know, is sort of the big international evidence-based medicine group. And people said the Cochrane reviews show a benefit of SSRI antidepressants in alcohol use disorder. So again, as a patient, and just coming with humility of what I would want to know as a patient, for instance, there was people who were arguing the Cochrane review for anxiety and alcohol use disorder showed that SSRIs were effective. Now, when we look at this review and actually just say, okay, well, maybe we'll take a second look at this. We did look at this, of course, as part of the guideline, but this is what it shows. The evidence collated as part of this review to determine the efficacy of medication in treating anxiety disorder symptoms with comorbid alcohol use disorder was inconclusive. They found some evidence of trials from serotonergic drugs, and they rated that evidence of being of very low quality. So if I was a patient with alcohol use disorder sitting across from a prescriber and they were reaching for their prescription pad, I would want to know that the reviews had shown that the evidence was inconclusive and that what evidence there was very low quality. So I think these reviews have kind of been misinterpreted by some readers. Here's the other review for depression and alcohol dependence. And there's a couple of things about these reviews that I should have said. One is that they consider tricyclic antidepressants, which was not of relevance in the Canadian alcohol use disorder guideline. We were agnostic on that because the literature is mixed. But it looked at tricyclic antidepressants, and also they excluded a lot of trials for reasons that I'll talk about. But this one's a little bit better for antidepressants when you consider tricyclics. You can see they found low quality evidence supporting the use of antidepressants, but most of these positive effects were no longer significant when studies with a high risk of bias were excluded. So again, I think as a patient who's looking for help, if the prescriber said, well, there's low quality, it's not very low quality, it's low quality, but most of the positive effects were no longer significant when studies with a risk of bias were excluded, I'd sort of be like, well, I want effective medication, not necessarily something like this. Now, another really important point, and this hasn't been raised by people that have sort of been saying that Cochrane reviews really are informative, is that a lot of studies were excluded because SSRIs have been studied for the treatment of depression and anxiety and in people with alcohol use disorder, but they've also been used to treat alcohol use disorder and studied in that context. And these are some of the largest trials that were excluded from the Canadian Psychiatry Journal and the Cochrane reviews. And the largest one is actually a Canadian trial. I'll just single it out and I'll present this to you by Charney. It was a CIHR funded double-blind placebo-controlled trial where we could actually see what happens when people get an antidepressant in comparison to placebo in a large sample size trial. So I think, that first truism is just, that they're not particularly effective. The original truisms are like, just as a matter of fact, it's not true. And then I'll take a little side trip here about sort of antidepressants and how their benefits are questioned in evidence-based medicine circles. And the reason that I'm going to do that is because I've had a couple of conversations with people, including medical journals and editors and others. And I think this is sort of what I've seen manifest a little bit, is that there's some people who think that antidepressants and the literature for them is like antibiotics for the treatment of bacterial infections. Like these are blockbuster compounds that, why wouldn't they work in people with alcohol use disorder? And the problem is that there's echo chambers in medicine. And you get the evidence-based medicine people go to conferences and talk. You get other people, specialists or family doctors, go to their conferences and talk. And I'm going to try and bring those worlds a little bit together and just give you a snippet here. But one of the main issues, if I can just distill it down, is that what happens in industry-funded clinical trials often isn't what happens or what you see in the journal articles. So I'm a specialist physician. I'm a professor at a university. Pharma knows about me, so they send me papers. I'll go to my mailbox at the center where I work, and there's a paper that's come from a pharmaceutical company. They want to know me they want me to know what this review article or what this journal article showed. And I've come to know now what is in those articles often isn't what actually happened in the trial. So with a little plug for the therapeutics initiative, this is just one but kind of famous example that I think if you're interested in antidepressants and evidence-based medicine, you should know about. It's called Study 329. It was a GlaxoSmith trial that really they tried to show that paroxetine was effective for adolescent depression. And it's kind of sad because I think it's still in the Journal of Adolescent Psychiatry, the original paper. It was ghost written by a communications firm, but they signed up a bunch of Ivy League people to put their names on it as authors. And the paper that's in this journal shows that paroxetine is safe and looks to be highly effective for adolescents with depression. So if you went to PubMed, you could find this journal and think, okay, well, paroxetine, I'm gonna try that. Well, people actually were able to get the original pharmaceutical industry funded pharmaceutical industry trial data, and it showed that paroxetine was no better than placebo, and there was a dramatically elevated rate of adverse effects, including suicides. And it's really just kind of one example. Here's another example. These are Cochrane collaboration investigators. They were looking at duloxetine. They had the clinical study reports that were submitted to, I think, the European Medicines Agency. So they had the data, the raw data from the trial, and you can see their conclusion. Clinical study reports contained extensive data on major harms that were unavailable in the journal articles. This is a last example that I like to give because I actually have a colleague who I really appreciate, a really smart psychiatrist and just a really, really great clinician. And he pointed out that this article from The Lancet was like a backbone article that the trainees really needed to know when they go for the Canadian Royal College exam that ranks the different antidepressants. And I sort of had some conversation, and he pointed out that he didn't even know that this meta-analysis had been reanalyzed, where investigators had the data from the clinical study reports. This is not small data. This is over 100,000 participants. In many ways, this is the definitive meta-analysis of whether antidepressants work. This is in the general population, and you can see they found the mean difference between antidepressants and placebo on the 17-item Hamilton Depression Rating Scale, which is 0 to 52 points, was less than 2. And you can see their conclusion. It's unclear whether antidepressants are more efficacious than placebo. So, obviously we're in a situation where there's echo chambers happening and people, talking about these things in evidence-based medicine circles, and then people going to, conferences where there's industry-sponsored talks and other things, and they wouldn't actually know in terms of what really happened in these trials. The other thing I mentioned that I often get systematic reviews mailed to me and end up in my mailbox at UBC. This information is coming at us through a fire hose. And addiction medicine, there's a lot of publication. And I would say every 1 to 2 years, there's probably another systematic review of the alcohol use disorder medication. So naltrexone, camprosate, there's Cochrane reviews. There's a Journal of the American Medical Association has an article that they update probably every 2 years. So I sometimes ask the addiction medicine fellows, how often do you think review articles are published on antidepressants? Do you think it's every year you would need to get up on the latest review paper, or 2 per year, or 3 per year? Well, investigators from Stanford looked at this question and they found in an 8-year period, there were 185 meta-analyses. It's like over 20 of these articles that are coming at us per year. And you can see their conclusion. There's a massive production of meta-analysis of antidepressants authored or linked to the pharmaceutical industry, and they almost never report the caveats about these drugs. So that's a detour. And I'm just like, for people who are really fixed in their thinking that these are miracle drugs and we know they're effective and we know that they work in people with alcohol use disorder, I hope I've softened you just a little bit to what I'm going to share next, which I think is really fascinating. And that's kind of the meat of the talk. So the two reasons that the Canadian Alcohol Use Disorder Guideline recommended against using SSRI antidepressants was A, what I've already shared with you, that the meta-analysis suggests that they're not effective. The Canadian Journal on Psychiatry analysis concluded with or without naltrexone, they don't look to be effective. But there's a really fascinating literature, which I think the vast majority of clinicians don't know about. My addiction medicine colleagues, I have friends in Boston who work at Ivy League institutions doing addiction medicine that were totally unaware of this literature. And it's really, really interesting. There's just an adverse effect profile that really you can step back and actually look at the general antidepressant literature, because pharmaceutical industry, they do a couple of things, and pharma is saving lives and doing lots of great things, so none of this is meant to be overly critical, but they do a couple of things. They do preclinical studies in animals, and they're looking for benefits and potential harms, and then they do a lot of phase 1 trials, and the phase 1 trials are really trying to look, who does this drug work best in, and where are their adverse effects. So for instance, if a drug were to, I don't know, let's say give elevated liver enzymes in patients with obesity, then the eligibility criteria for pharmaceutical company A's drug B would exclude people with obesity, because the last thing that they want is the US Food and Drug Administration or Health Canada to see, wow, well, it causes elevated liver enzymes, we can't approve your drug. So that there should be a footprint of this, that we could just go back and look at how these trials and things were done and see what happened. And this is just an example of that. This is some psychiatrists, I think from Brown University, who ended up questioning whether the routine exclusion of patients with substance use disorder should be reflected in a product's label. And the reason is, these are not substance use disorder trials. These are the trials to get antidepressants approved for the general public, where they looked at the eligibility criteria, and over and over and over again, people with alcohol and other substance use disorders were excluded. And so the point that they're making here, in Canada, we have product monographs. In the US, they have product labels. This notion that, hey, we don't know if these drugs actually work in people with substance use disorder because for some reason, the pharmaceutical industry excluded those people. And there's really no reason to. Let's say 10% of people with depression in your clinic could get rolled in the clinical trial and they had problems with alcohol. You would randomize them to placebo or your drug. 5% of your total study in each arm it has problems with alcohol, and you could see what happens with the antidepressant. Well, obviously industry did not want that. There's also lots of preclinical studies like these. This is just an example. You'll see they noted some studies suggest that the use of antidepressants could worsen prognosis in alcoholism. In this study, they gave these animals fluoxetine and venlafaxine, and they found that both antidepressants increased alcohol consumption. So this thing with the Canadian alcohol use disorder suggesting it could worsen outcomes is not new, as you will soon see. Now, this is interesting too. I've seen case reports. This is the only case report I'm aware of where, there was 93 cases in this one paper. That's more like a cohort study in some ways, but they found this is different. This is the emergence of new onset alcohol use disorder secondary to the use of an SSRI. Now, you may say, well, that should be reflected in the trials, shouldn't it? And actually, Cochrane collaboration investigators looked at industry-funded trials with the intention of observing adverse events secondary to SSRIs involving alcohol in the antidepressant arm versus placebo, and they found that they could not do that. It was something like 90% of the trials they identified. The industry trials did not measure alcohol-related outcomes, which to me, I think is, kind of a missed opportunity. You can see the conclusions of these investigators. SSRI-induced alcoholism is likely to be a relatively common problem. Recognizing the problem can lead to a gratifying cure, which in this case was switching to a non-SSRI antidepressant, a tricyclic, and failure to recognize it can be fatal. And again, think of our case where the prescriber's intervention was to up the dose, because of course they weren't aware of the literature that I'm about to show you here. So there are these reviews, there are Cochrane collaboration reviews. What do these trials show? And I think none of this is really new. You have to go, way back in the literature. And, for a kind of evidence-based medicine nerd like myself, it's kind of fun. So I'll take you back in what these trials kind of showed. This is going all the way back to 1996. You have to worry in these small trials where there's a big risk of a type 2 error, which is where there's a difference, but it's not statistically significant because the statistical power with such a small sample size is low. But they randomized a small number of people to fluoxetine in comparison to placebo. Again, I think this is the first trial, but I could be proven wrong. And they found about a 20% difference in comparison to placebo and fluoxetine, about 20% less relapses. Now, for people that are in sort of cardiology or other areas, they'll know there'll be 10,000 people in a study and there'll be a 4% difference. And, the investigators jump up and down about this great intervention, about how better this new beta blocker is than the old one or whatever it may be. But here, this is a 20% difference. It's pretty substantial. That same year, 1996, Kranzler and colleagues observed something, and I need to define a couple of things here. There's an older nomenclature where individuals with type B alcohol use disorder, they tend to develop more severe problems early in life. So in British Columbia, we have Foundry clinics to help young people with mental health and substance use challenges. They'd be more likely to show up at a clinic like that. Or if their parents were well-to-do and they were connected to healthcare, they might get referred to a psychiatrist or an addiction medicine physician for evaluation. They're more likely to get in fights or, sexual assaults or end up with things happening in early life, severe alcohol use disorder, the type of people who need treatment. A type A person with alcohol use disorder might develop alcohol problems, in adulthood or even in their elder years. They tend to have less severe consequences. They're much less likely to come into contact with healthcare. So Kranzler and colleagues found here that actually if people got CBT plus placebo, they did better than if they got fluoxetine. And you can see their conclusion here, a medication-mediated reduction in the beneficial effects of relapse prevention training, such as appears to be the case in both the study and the study by Covey et al. And the present study, has important clinical implications that are underscored by the widespread use of fluoxetine. So again, that sort of truism that an SSRI plus a mental health intervention is the sweet spot. I'm not going to show you the Covey et al. Study, but the Kranzler and Covey et al. Are sort of saying it looks like people did better if they got placebo. Kranzler and colleagues then came back many years later because there's lots of, I'm just sort of showing you some of this work. There's lots of trials like this, and they hypothesized that there was actually a genetic a serotonin transporter gene that would predispose to a worse outcome in individuals with early onset or type B, and that actually there might be a benefit if people were later onset, less severe alcohol use disorder. And this is what the trial showed. They used sertraline in this case. The placebo and the sertraline group were both drinking about 1 to 2 days per week at the start of the trial. And if you got randomized to sertraline, you were drinking heavily about 7 days a week by the end of the trial in comparison to the placebo group where there was no change. Now, it was more subtle, but they did show actually a benefit in the late onset, the sort of type A individuals. It looked like there was a benefit. The rub was that they did this genotype and they had genetic data about the entire US population, and they estimated that the gene that predisposes to a worse outcome in alcohol use disorder if you get an SSRI is about twice as common in comparison to this gene that they hypothesized would enable the SSRI to be effective. There's another thing that speaks to some of the truisms about this trial and other trials as well, is they often stopped the medication and they watched to see what happened with people over time. Because with lots of medication trials, the placebo and the intervention group will come back together. And what they showed actually in this trial is that these individuals continued to do poorly even though the antidepressant was stopped. And that's been shown in other trials. I don't know why that is. I know that sexual side effects of antidepressants can persist long after a medication is stopped. And maybe there's something with that, or maybe people just spill over into such severe alcohol use disorder that it's difficult to bring them back to where they were at baseline. This is the trial that I mentioned was not included in the Canadian Journal on Psychiatry review. It's not included in the Cochrane reviews. I don't want people to misunderstand and think there's something nefarious about that. The reason that it's not included is because in this case, citalopram is being used to try and treat alcohol use disorder. So not everybody in the trial would have had depression. They're really trying to see, can we help people with alcohol use disorder by giving them citalopram or not? And in the context of a severe alcohol use disorder, it's kind of hard to make a depression diagnosis. So this is really going to tell you. Some of the studies I've been showing you are very small sample size. This is like the size in mental health and addiction of a phase 3 trial. 265 people got randomized to citalopram or placebo, and you can see their conclusion. The results suggest that the use of SSRIs among depressed and non-depressed alcohol-dependent individuals in early recovery prior to the onset of abstinence may be contraindicated. And the reason that they drew that conclusion is there's a table in this paper where all of their outcomes comparing citalopram to placebo look like people did much, much worse if they got an SSRI in comparison to placebo. Again, for people who are like, well, the Cochrane reviews show a benefit, like please fold through that article to look at the trials that were excluded. This is just one that show really, dramatically worse outcomes. What about trazodone? Again, with the literature would show from the therapeutics initiative here, but certainly US surveys elsewhere in Canada, trazodone is the go-to drug to help people sleep with alcohol and other substance use disorders. And there's only one big trial of trazodone. It's about 200 people, a little bit less than that. And you can see their conclusion: trazodone, despite a short-term benefit on sleep quality, might impede improvements in alcohol consumption in the post-detoxification period and lead to an increased drinking when stopped. That's kind of a polite way of saying, in comparison to trazodone, those in the placebo group drank less. Like this other trial that I described, they followed people afterwards, and they showed that people in the trazodone group continued to do worse in comparison to the people that got placebo. So remember that truism where I said, well, it's just try medications for several months and see what happens. That's not true. You can have a dramatically worse outcome for people that persists even after the medication has been stopped. And what about advocacy for trazodone? So when the Canadian Alcohol Use Disorder Guideline was published, there were people who were saying, well, higher doses of trazodone. That study I just showed you, the dose of trazodone was too low. And for me, I welcome somebody to email me if they can think of an example, but I don't know of instances where raising the dose of a medication reduces side effects. The fish curve, for those people that are familiar with that, that just is totally inconsistent with what I think, would be true. But it also shows that we're in a situation where there are thought leaders in Canada that are advocating for sort of higher doses and use of a medication like this in alcohol use disorder who actually don't know some pretty important literature, I think, or at least haven't shared their knowledge of it when they're advocating for trazodone. And that's that trazodone is metabolized into a psychoactive metabolite called M-chlorophenylpiperazine, or MCPP. It's an interesting story about MCPP. It's actually illegal in a number of European countries because it has psychoactive effects and it gets used as a cutting agent in drugs like MDMA and others. That's neither here nor there for our purposes. For our purposes, MCPP has been studied in enough trials that it's known to increase alcohol craving in so many trials that at the NIH, they use it to pharmacologically induce alcohol craving to see if certain interventions will reduce alcohol craving. And in this study, they found that alcohol craving was insensitive to acamprosate. Now that's interesting, but that's neither here nor there. My point is that so much is known about the trazodone metabolite in inducing alcohol craving that NIH investigators use it to induce craving. And we have a circumstance where people are advocating for use of trazodone in alcohol use disorder. I think they just don't know that literature. There's other trials which I'm not going to share for the sake of time with nifazodone. It's no longer available in Canada. It's an analog of trazodone. It's available in the United States. MCPP is its psychoactive metabolite. There's a multi-site German trial that used nifazodone in alcohol use disorder that similarly showed increased drinking in comparison to placebo. So what about polysubstance users? This is to suggest that people come into clinic only using alcohol or only using cocaine is naive. Cannabis, tobacco, other things, are the norm. So we can look at some of these trials and how antidepressants perform in that context as well. And I think, again, this is literature that people just are not familiar with. This is a trial of people with opioid use disorder on methadone who were struggling with cocaine, and it was a contingency management intervention where people were incentivized with vouchers. And you can see here the placebo voucher group had the longest treatment retention. Now, retention is critical in opioid use disorder, and the lowest probability of cocaine use if they got placebo and voucher. So if they got the drug, in this case fluoxetine in a voucher, they did worse, okay? You can see here fluoxetine was not effective at reducing depressive symptoms, and they concluded that fluoxetine may actually attenuate the efficacy of vouchers, and they got into possible mechanisms talking about apathy. Here's another trial of fluoxetine and cocaine dependence in individuals with depression and stimulant use disorder from cocaine. You can see fewer positive urines were found in the first 6 weeks of treatment in the placebo group compared with the 40 milligram fluoxetine group, and there's no benefit for depression, okay? No benefit at all and increased cocaine use. Here's a randomized trial of sertraline and contingency management. So this incentivizing people with vouchers type of model is proven to work in stimulant use disorder. So it's an intervention that's often included. And you can see these investigators concluded these data do not demonstrate improved outcomes for sertraline. Indeed, they suggest sertraline is contraindicated for methamphetamine dependence. Now, methamphetamine does a hatchet job on people's mental health. They're routinely become depressed. And, if I had a nickel for every time I had somebody come into my clinic for help with withdrawal management using methamphetamine and on sertraline or other SSRIs, I'd have a lot of nickels. And it's difficult because you have to then explain to people, did anyone tell you that this medication is unproven in people with stimulant use disorder? And these investigators here actually had a paper showing that sertraline is associated with sustained craving for methamphetamine. And do you know that it might actually be part of the problem in your case? And people look like, they're just gobsmacked to learn this information. just bouncing around because lots of people with alcohol use disorder use cannabis, venlafaxine. You know, I see a ton in people with substance use disorder. You can see the conclusion of these investigators of this double-blind placebo-controlled trial. For depressed cannabis-dependent patients, venlafaxine extended release does not appear effective at reducing depression and may lead to an increase in cannabis use. For the sake of time, I elected to not show nicotine use disorder and tobacco trials, but I'll share with you the largest trial conducted of an SSRI in people with nicotine addiction showed a greater rate of relapse on the 2 SSRI doses in comparison to placebo. So going back to this meta-analysis, these investigators did a really good job. It's a really nice paper. Their conclusions are well stated in the abstract. And something that they did, which is really important and most of these reviews do, is they look for the question of publication bias. Now, this is something, I don't want to confuse people. I've talked about biased studies and that the papers, what appears in those papers isn't really what happened in the trial. And the Cochrane reviewers, you might remember, said there were studies with a high risk of bias. That's usually things like they went on a data dredging exercise to try and show benefits, and it really looks like there wasn't a pre-specified statistical approach or a primary specified endpoint. Publication bias is different. Publication bias is when the investigators or the company, it's not always industry-funded research where this is a concern, decide not to publish negative trials. So they've gone out there, they've hoped to show that this SSRI is effective for treating alcohol use disorder as an example, and then it ends up having bad side effects, and so they choose not to publish it. And so when you're doing meta-analyses and reviews like this, you just don't know. You don't even know what happened in those trials. And this is a really big problem in evidence-based medicine circles. You might be saying, well, how do you calculate a statistic then? Essentially, there's like a normal distribution around the estimates in your meta-analysis, and it should be kind of like a Christmas tree. And if you have the sort of positive end of the Christmas tree, but there's no negative trials there, then you can get a significant result like this. And I'll share some examples because I actually saw a presentation that was in reference to SSRIs and alcohol use disorder. And the person who gave the presentation tried to say there was no publication bias. This is an area of medicine where there's huge problems with publication bias. Again, stepping away from alcohol use disorder, this is just antidepressant trials in general. This is really fascinating. This was some psychiatrists from Brown University where they had the data from the US Food and Drug Administration to get antidepressants approved for the general population. And they found that there was about 80 trials. There's a lot of trials that were done. And then they went to the literature to find those trials. And lo and behold, about half of the trials were never published. And when they actually looked at those trials, they were the negative trials. All, I think, except one of those trials showed that the SSRI intervention, or the antidepressant intervention, I should say, with these are ineffective or harmful. And so the companies elected to not publish it. What's also interesting and maybe not a surprise based on what I shared previously, among the other half of the trials that were published, like study 329, they were written in a way to sort of imply a benefit of an antidepressant that when actually the investigators looked at the data that the US FDA had, it probably wasn't as glowing as the investigators had made it out to be. So again, I saw a presentation where someone said there was no publication bias, and I've had the opportunity, you know, this is a true story. I had a no-show in my clinic for a patient, and I knew about this New England Journal of Medicine trial, so I just went on the NIH website. This is not industry-funded trials. This is publicly funded trials, and you can see very quickly I was able to find an SSRI trial for antidepressants. I went to clinicaltrials.gov, and it had been registered. For people who don't know about registration of trials, it's really important that you register them, and journals require it before your study is started. And that's how we know that unpublished trials exist. And this is an unpublished trial because not only did I go to PubMed and I wasn't able to find the trial, but you can see here no results were published on clinicaltrials.gov. So these investigators, I sent off an email because their contact information was here. They very kindly got back to me. They said, yeah, we decided not to publish it, but here's the poster if you want to cite it, because we did present it as a poster. Again, this is not in the systematic reviews because there's no paper with the fulsome data, but you can see here they actually found that the serotonin transporter genotype, if you're kind of sitting here thinking, oh, maybe there's a personalized medicine approach we could use by genotyping to avoid SSRIs here and use them there. This is sort of the definitive trial meant to answer that. And that whole business with type A and type B, of course, the Charney study that I showed you, just everything was worse if people got SSRIs in comparison to placebo. But the serotonin transporter gene doesn't look like it was helpful. And they found that participants whose goal it was to abstain from drinking tended to have fewer days abstinent on citalopram compared with placebo. Tended to me sometimes means like the p-value is 0.06 or something. It was not. It was highly statistically significant when they looked at this. And obviously, if you have a patient in your clinic who's trying to reduce drinking or abstain from drinking, this study would say that giving an SSRI was harmful. So I think I've interrogated these truisms. Again, I don't want to imply that people who are sort of advocating for the old way of doing things have a secondary interest. I think everyone is just trying to do what's best for patients. But if you look at these truisms and then you go to the literature, it's really hard to defend them. And I think there's reasons that practice change is warranted. So returning to our case, obviously, the use of an SSRI is unlikely to provide benefit for mood or anxiety, according to meta-analyses. You have to squint very, very hard to imply that that's going to be beneficial. Longstanding evidence, including from large RCTs and the largest ones really in this population, demonstrate potential for increased use. And in this context, so many of the people's anxiety and mood disorder or sleep problems is secondary to the alcohol use in the first place. Similarly, trazodone has similar risks for increased drinking that may persist even after it's stopped. That's probably because of this psychoactive metabolite that is known to increase alcohol use. And these observations are obviously seen in other substance use disorders where serotonergic antidepressants have unproven benefit for reducing depression and may worsen outcomes. And really, that's across the board, as I've shown you today, at least in these individual trials. So a couple of final thoughts. Polypharmacy is very common among persons with alcohol and other substance use disorders who are often being treated for the side effects of substance use. You know, that, like I said, I think the case in the therapeutics letter is an individual who has a panic attack in a shopping store lineup. And, you know, alcohol use disorder, it's part of you get adrenergic symptoms that can feel panicky or cause poor sleep just by virtue of alcohol withdrawal. The likely explanation is that negative trials are often unpublished or poorly represented in reviews or overall poorly appreciated by prescribers. You know, in a 40-minute talk like this, I hope you can appreciate this is just the tip of the iceberg in terms of this story. And I hope that, you know, evidence-based medicine practitioners will continue digging in this area because, again, I think we've really just scratched the surface. Obviously, an evidence-based medicine approach suggests that we prioritize safer mental health interventions for these common comorbidities. And I wouldn't want to like give the wrong impression that I'm not a huge advocate for treating low mood, anxiety, poor sleep. That can be really important. For some people, it's critically important. I just think we need to focus on things that are likely to help with that, and certainly not things that are going to drive people into more severe substance use disorder. It obviously highlights the need to be aware of medications with poor evidence of benefit and be vigilant for side effects. So I've personally seen this where people come in and I get a history and it's like, so when did things really sort of go sideways with your drinking? It's like, oh, well, I was feeling bad. I was feeling kind of anxious. I was probably drinking, you know, half a glass of wine to half a bottle of wine every night. It was too much, but I went and saw my family doctor. They started an SSRI. And then in one case I can think of, the individual was going to the liquor store in the morning before it opened to get a 26er of alcohol that she was drinking every day. All I did was stop the SSRI and we put her through withdrawal management and she hasn't gone back to drinking for over a year. Obviously, when serotonergic antidepressants are used, prescribers should warn patients with substance use disorder about the unproven benefits and be vigilant to watch for adverse effects, including increased substance use. So I'll just pause there. I didn't bring up the names of all the individuals with the CRISM alcohol use disorder guideline because my presentation today has gone well beyond that guideline. But I will say, I think on the entire committee's behalf, nobody had an agenda or a secondary interest. Everyone was really just responding to the committee and wanting to do, you know, what was best from a patient perspective in terms of what could be effective. Our funders and other supporters are there as well. And I'll just pause there and turn things back over to Aaron and happy to take some questions.
Thanks, Evan. Great, amazing amount of information so clearly presented in such a short period of time. So, Evan, there's a flurry of questions and comments in the chat. I'll start with one of mine, and then I'll move on to the others. So you talked early on about if there was a systematic review of cardiovascular medications, and they suggested that some medications would be harmful, people would act quickly or differently than what's happening here. Why do you think it's different in this realm versus like why are people slow to or maybe not paying attention to the stuff that you've presented?
I think it's multifactorial. There's a nice JAMA article talking about addiction medicine, and I think the title is "The Birth of a New Discipline." And I think just, it is a new area, whereas, cardiology uniquely gets a huge amount of funding, not only from pharma, but epidemiologists that focus their energy in that area. This has just received a lot less attention.
Mm,
Historically, this is the first Canadian national guideline for alcohol use disorder that we were involved with. That I think there's stigma and a lack of funding for guidelines. It's just been a totally neglected area, and it's just playing catch up. I think there's a host of reasons from stigma to funding, lack of trained practitioners. We have a fellowship to train addiction medicine physicians that's interdisciplinary, including psychiatrists, primary care
mhm.
providers, internists, and allied health disciplines. That's new. If that had existed 20 years ago, we might be farther along. So there's a host of reasons why, but certainly, I think addiction medicine has a long way to go in terms of becoming more evidence-based for sure.
Okay, thank you. And on to some of the questions from the group. So I'm going to combine two questions. Someone's asking about SNRIs, and someone's asking about semaglutide for alcohol use disorder or substance abuse disorder. So any general comments about those two?
Yeah. The Canadian Journal on Psychiatry review, again, I think you'd have to go to it and decide for yourself, implied that maybe there was some benefit with imipramine in terms of substance use disorders and antidepressant effects. But I think that we don't have great tools where I could say, actually, you know what, we've got this, this great medication. I don't think we really have that yet. For me, the tricyclics, I'm not aware of trials showing worse outcomes. You have to, of course, cardiotoxic effects of tricyclics and other things. We can have a whole conversation. But for me, I don't want to give someone when they come into my clinic saying, I really need help with my drinking. I've been kicked out of my house. I'm going to lose my job. I've lost my driver's license. I do not want to pull out my prescription pad that's going to lead somebody to drink more. And as far as the tricyclics are concerned, I'm not aware of studies like that. In terms of the new obesity and diabetes drugs, I think the jury is still out. There's a lot of interest, but I think the TI actually did a review of that, and I was a reviewer of that, and I would say there's a couple of conflicting small trials in the journal. The jury is still out.
Okay. And sorry, SNRIs? You mentioned tricyclics.
Yeah, I mean, I presented some of the SNRI data today. Obviously, bupropion and can be effective in tobacco. Some
Hmm.
people think there's maybe a signal of benefit in stimulant use disorder, but I think, in substance use disorder, it's usually the substance, the biological effects, or the social effects. And I wish we had happy pills that could, make those
Sure.
problems go away. I just
Mhm.
don't think we have effective drugs in that context. And really, from a motivational enhancement perspective, really helping people to understand the literature that there's really dramatic improvement in anxiety and depression when people reduce or quit substance use. That's been known for decades. I could have spent my whole talk today showing paper after paper showing the benefits of a reduction or abstinence from substance use and improving mental health outcomes. Of course, we need to build a functioning substance use disorder system of care to help people with that, which we don't have right now.
Okay, there's a flurry of comments and discussion around ADHD and stimulant use. So maybe I'll tease out a key element that relates specifically to your presentation today. So the comorbidity of ADHD and substance abuse and the use of stimulants, what's in your head about that and how it impacts what you're talking about today? Like, is it undertreated ADHD or are they linked? What are your thoughts when I bring that up?
A bunch of thoughts come up. First of all, that it's separate from antidepressants because we're talking about stimulants now. There's dangerous overdiagnosing of ADHD, and that's been shown. There's a Canadian paper, the New England Journal paper, depending on what month you're born in the year and your likelihood of being diagnosed with ADHD. The older kids in elementary school are much, much, much less likely to get a lifelong diagnosis simply by virtue of their calendar month of birth. I
Hmm.
also am aware of like you open up a newspaper and there's advertisement for adult ADHD clinics. So there's sort of financial incentives to get people with this diagnosis. So those concern me. Putting that
Hmm.
aside, there are people that struggle with ADHD. It's a very real thing.
Hmm.
And some of them get into substance use. And studies have shown that stimulants prescribed, this is a mixed literature, but there's some
Hmm.
literature to suggest that that can be a risk factor. So that's something to be aware of. When people get into using stimulants, they get a lot of psychosis. And so prescribing stimulants in that context can also be risky. But the literature in terms of the Cochrane review using stimulants for the treatment of stimulant use disorder looks like the biggest benefit is maybe in people with ADHD. So I would say if that sounds like a dog's breakfast, it's probably because the literature is a bit of a dog's breakfast. And I don't think that there's a big solution to suddenly go guns blazing using stimulants in this context, but safely diagnosed and safely prescribed, there may be a place for it in some instances.
Okay. Any proposed mechanism, or where are you putting your money in on why SSRIs may make things worse? What is the explanation?
It's funny because if you get into sort of the substance use disorder world, if you get into addiction medicine, it's dopamine. It's dopamine. That's the neurotransmitter that teaches us. It's sort of our educational neurotransmitter, and it gets us to repeat things that are likely to increase our survival. That's why on a hot day, when you're dehydrated, that water tastes so good. A fatty meal or a sweet meal or having sex, that's dopamine. And so
Hmm.
everything is about dopamine in addiction medicine. But neuroscientists, the PhD neuroscientists that really study this stuff, is
Hmm.
these neurotransmitters are all connected, and serotonin certainly does play a role in teaching us. It does play a role in the reward pathway. And so
Yeah,
whether it's the stimulant effects or the impulsivity that can come with it, there was that one study that implied, they thought people were getting apathetic on antidepressants, on
mm,
SSRIs. There was another study that showed sustained craving for methamphetamine with sertraline. I don't know, but I think I know enough in terms of, there's no really compelling reason to prescribe them. And it looks like people oftentimes, not always, will do worse in comparison to placebo in terms of the types of differences that would influence prescribing decisions in other contexts. But
mm.
probably that's a question better for a neuroscientist that studies the role of serotonin in substance use disorder.
Yeah, complicated for sure. You had mentioned how stopping antidepressants and then the problem still persists and they haven't really figured out what's going on. I just refer people to a webinar we had by Mark Horowitz several months ago talking about antidepressant withdrawal and his ideas on the neurochemical imbalance that occurs when you've been exposed to antidepressants and how that takes time, or in some cases may never completely reset to baseline neurochemistry. And so that may be a part of it, but he had some interesting thoughts.
Super interesting. And I saw that webinar. I encourage people to see it too. I'll share this because this jumped out at me when I was looking at some of these preclinical studies because I was just curious. They were
Mhm.
doing like cross sections of these animal brains. You can't do this in humans, obviously. And it was very obvious when the pathologists were looking at the animal brains, which had got the SSRI and which hadn't. So this isn't something that just sort of we metabolize and it goes away. The chronic exposure to these medications, it's a neuroplastic brain and neurotransmitters respond, receptors respond, and we shouldn't expect these things to go away overnight.
Sure. Okay. Okay. Someone's carefully written out three questions for you. I'm going to relay them. In light of your concerns about the difference in conclusions when original data were not available, I was wondering if you're able to get your hands on the original data for the studies you have shown that conclude that SSRIs cause harms. Have you reached out to authors or attempted to get more?
Yeah, so that's describing other people's work. I
Mm-hmm.
will share my personal views that I have yet to see. I think there are in evidence-based medicine circles people that are really trying to advance the public good by trying to identify medications that are effective. Maybe there's a generic alternative that's just as good, or maybe it's best in this context or whatever it may be. And I kind of view the therapeutics from that lens, not as a member of the therapeutics initiative, but like not anti-medication, but trying to like let's work in the public good for when medications are effective and avoid when they're not. When it
Sure.
comes to this sort of critique of antidepressants, I think that comes from sort of the evidence-based medicine world. When it comes to conducting antidepressant trials, you may have noticed that all of the trials I presented, I think every single one are from psychiatry groups. Usually, they're
Mhm.
often funded with free medication and free placebo from the pharmaceutical industry. And I think people are genuinely building on their experience with using antidepressants in practice, trying to show a benefit. So if people think there's sort of this nefarious thing like that Charney trial to show that antidepressants don't work, and if we could get the original data, it would show something different. If anything, I think there's an overwhelming bias towards trying to show that these medications are effective. And
Mhm.
despite that, the meta-analysis shows no benefit. But that's my personal opinion, and I would welcome anyone to try and get that original data and critique it. The Charney study, the largest one, 265 patients with citalopram that did worse in every way, I think uniquely was funded by CIHR. It wasn't an industry funded study, but it was still a group of mental health experts that I think genuinely this was a finding they did not expect.
Very interesting. Yeah. I mean, from personal experience in doing systematic reviews, I can tell you that, the issues you talk about studies and publication bias and reporting bias, those are real. I've encountered them in areas other than mental health. So another question is, you noted that the studies that looked at SSRIs in substance abuse and alcohol use disorder were not necessarily designed to look at these outcomes. So do you have any comments of what would that look like? What kind of metrics would you do? What could be done in the future to make the evidence base more definitive?
To be honest, I think the evidence base is definitive, and I hope I didn't
Okay.
confuse anyone. I'll use this opportunity to clarify. So there are trials with people with depression and with in alcohol use disorder or other substance use disorder, and that's the eligibility criteria. You had to be depressed, you had to have a substance use disorder, you're in. And when those trials get meta-analyzed, there's no evidence of benefit. My
Okay.
concern and what I've shared today is that those meta-analyses don't consider the other trials where SSRIs were used to try and treat the substance use disorder. Because not everybody had depression, those meta-analyses of depression and substance use disorder exclude them. But
Hmm.
they're still really important. There's these really nice studies, almost 300 people getting an SSRI versus placebo, and we can see how this impacts on their alcohol use disorder. And in the case of that Charney study, the largest study, people got dramatically worse. So I think we have studies in the absence of everyone having depression. We have studies where it was in the eligibility criteria. But, I'm not anticipating some new study that's going to add to what we know. If you read the discussion sections, and I was doing some of this morning in preparing for this talk, the investigators sort of say it does not appear to be fruitful to further pursue SSRI antidepressants as treatments for substance use disorder in stimulant use disorder or alcohol use disorder. I think, if there was a signal of benefit, it would probably come out in meta-analyses, but when these trials are brought together, there really isn't a signal of benefit.
Okay. And I guess the flip side would also be true that one or two studies showing something other than what you're suggesting would not overturn the volume of evidence we already have. So,
Yeah, I would say the meta-analyses that have been done are
mhm,
really trying to gather, all of the trials. The
sure.
trials that I've shared today are underrepresented in those reviews if not everybody had depression or not everybody had anxiety, or, that cannabis use disorder review, for instance, is in the Canadian Journal on Psychiatry paper. So I first Googled the first author's name and then thought, okay, let's hear what they have to say about that paper. And it's in the tables. It's in the tables describing the papers, but there's no mention of that potentially causing a worse outcome. Now there's word constraints with journal articles and stuff, but I don't think this has just got the attention that the adverse effect profile may actually include worsening substance use disorder. That's really underrepresented in the literature as far as I can tell. These papers that have negative results, I feel like people just park them and then they go on pursuit for a new drug that might work. And it's like, well, we did that trial. It told us something. It told us that this is bad. We're looking for things that are good. good. And the reviews are often like that too. We're looking for the things that work, and things that don't work don't get a lot of airtime.
Here's a maybe a tough question. What's your response? Apparently, there was a letter written to CMAJ with concerns about your guideline. Do you want to speak to that?
Yeah, I mean, first of all, I'd encourage people to go to that letter.
Hmm.
That's on the CMAJ website along with our response. They only gave us 250 words to respond, but I think we did a pretty good job. That letter, for instance, included suggesting that using a higher dose of trazodone, like I talked about. Oh, use a higher dose of trazodone and you won't see the side effects. I mean, like I've shared, higher doses of drugs tend to induce worse outcomes. And
Hmm.
obviously, that MCPP issue of a metabolite known to increase alcohol craving. The letter suggested that the Cochrane reviews showed a benefit in with SSRIs. I think I've shown that the actual conclusions of those reviews are that it's inconclusive or that there's very low evidence, and that also considered tricyclic antidepressants. So there was those. The letter included some non-randomized studies. So I mean, I just encourage people to go to those letters, absolutely. But nothing in those letters I haven't addressed today. And I think the
Okay.
guideline committee as a whole is like, guys, let's be evidence-based medicine practitioners here. Let's try and advance the cause of patients with safer prescribing. And none of the arguments there. Just go and read the letters. I mean, to me, I was kind of like, ugh, this is pretty easy to bat down these types of criticisms because they're just not really evidence-based statements to be made.
Okay. Fair enough. Here's a question. Does long-acting benzodiazepine have the same effect as antidepressants in terms of cravings for alcohol?
Great question. Great question. Because we talk about antipsychotics in the guideline and benzodiazepines. This is so common. If there's any primary care providers that see people with alcohol problems in their clinic, I'm sure that's all of you. It's so common to have someone come in and say, you know what, I'm drinking too much. I need help, and give a short course of benzodiazepine to help with withdrawal. So 3 days of diazepam, come back and see me next week. And so the studies show that compare benzos to alternatives, and there's probably 5 trials of different alternatives like gabapentin, different drugs that have been tried. When you use a benzodiazepine, and this has actually been shown in laboratory studies as well, where people have access to alcohol, they drink more. So the alcohol use disorder guideline discourages the use of benzodiazepines unless it's necessary. If someone has had seizure, DTs, they have really severe withdrawal, then the standard of care is benzodiazepines. For someone who's never had a seizure, they've never had DTs, they're looking to cut down, the Canadian Alcohol Use Disorder Guideline not only describes risk scoring tools that can be used, but also safer alternatives. Avoid benzodiazepines in people with alcohol use disorder whenever you can because it primes people to drink more. That's been well described.
Okay, so just to clarify, benzos might be useful for the symptoms of a severe acute withdrawal, but not to treat the disorder in someone that's not going through acute withdrawal.
Yeah, because of the
Okay.
influence on the GABA receptors of alcohol and benzodiazepines, there was a thought maybe, for people with severe alcohol use disorder, give them benzodiazepines as like a replacement therapy. And when you
Hmm.
give people with alcohol in a laboratory benzodiazepines or placebo, they drink way more. And double-blind placebo-controlled trials looking at withdrawal management methods show that
Hmm.
benzos tend to result in higher rates of relapse in comparison to placebo. Only use them when you need them.
Okay, great. There are a couple questions about anxiety, generalized anxiety disorder with or without depression. And so, do you have any comments about not only SSRIs, but how do you deal with someone with that as well as depression or on its own without depression?
Yeah, super challenging when you're anxious. I mean, I was anxious before I gave this talk. If I'd had a pint beforehand, probably
Yeah.
would have cooled me down a little bit. Unfortunately, because of the plasticity of the brain and the way that receptors internalize, et cetera, you're going to get, rebound anxiety from alcohol. So people with anxiety disorder, it gets worse with alcohol, but
Hmm.
they think it's helping them. It's really challenging. First of all, I think I've shown today reaching for an SSRI in that context. The Cochrane review showed no evidence and
Mhm.
there's evidence that it could prime someone to drink more. We just went through this actually at Vancouver Detox because we really struggle with people in acute withdrawal wanting something for their anxiety. They're having panic attacks or they feel terrible. And we've just started implementing the opportunity where the counselors have time and they're kind of overwhelmed, but to help people with like box breathing and other cognitive strategies, non-medication based strategies to avoid that kind of chemical, non-chemical coping strategies and building strategies for dealing with anxiety. So it's really complicated, but ideally, in a functioning a system of care for people with substance use disorder, we could go with safer medications. In acute withdrawal, we try gabapentin because it can take the edge off for people. But for anxiety disorder, really looking, I think, to avoid medications that can be harmful, and for
Mhm.
interventions, psychosocial mental health interventions, and other interventions that may help people. But that's a challenging clinical scenario. There's no doubt about it. Because usually when people are coming with alcohol and anxiety, they find that the alcohol is helpful. And really, because of rebound anxiety, that's part of the problem.
Sure. Okay. Someone's brought up the fact that there are some studies where naltrexone was on board when SSRIs were started in people with alcohol use disorder. Do your concerns around SSRIs or trazodone, do they apply in that scenario as well?
Yeah, I think I demonstrated in that Canadian Journal of Psychiatry meta-analysis. They showed that SSRIs either alone or in combination with naltrexone or other relapse prevention medications showed no benefit. And when you look at other substance use disorders, usually retention in care is reduced in comparison to placebo when you add an SSRI, as well as, more side effects, only some of which I've addressed today. So yeah, combining an SSRI with other medications is of unproven benefit, and if anything, the meta-analysis show it doesn't work. So that's an important question that that Canadian Journal on Psychiatry meta-analysis you can go to if you want to know more.
Okay. So I'll just take this opportunity to thank everyone for signing into the webinar. I'm sorry we didn't get to all of the questions. We tried to get to as many as we could. I really appreciate your time in signing in for the webinar. Dr. Wood, amazing presentation, lots of useful information, a very challenging topic. Thank you so much for sharing your knowledge with us.